Welcome to this webinar about engaging with academies to enable evidence-based health promotion. This webinar is based on a project funded by the NIHR School for Public Health Research. Established in April 2012, the School for Public Health Research is a partnership between 8 leading academic centres with excellence in applied public health research in England. Researchers in Bristol, including myself, Tricia Jessamine, and Professors Rona Campbell and Russ Jago, with Dr. Esther van Sluis at the University of Cambridge and Professor Dorothy Newbury-Birch at Teesside, led the study. It was funded by the School for Public Health Research, and the views expressed here in this webinar are those of the authors and not necessarily those of the NIHR or the Department for Health and Social Care. Academy schools are publicly funded state schools in England, but are independent of local authorities and receive their funding directly from the UK Department of Education. The Academies programme began in England in 2000 under the Labour government as a means of addressing underperforming local authority maintained secondary schools through the provision of sponsorship by an external partner from sectors including business and industry, philanthropy, universities, religious groups, charities and others, including other high performing schools. The coalition government of the Conservatives and Liberal Democrats expanded the remit of the programme in the 2010 Academies Act to include high-performing primary, secondary and special educational needs or disability schools, as well as pupil referral units and 16+ institutions who could opt out of local authority control by applying to convert to academy status with or without a sponsor. Academies don't have to follow the national curriculum and can set their own term times. They still have to follow the same rules in admissions, special educational needs and exclusions as other state schools. As this table shows, as of September 2019, there were nearly 9,000 open primary and secondary academies and special and alternative provision in England. This equates to 34% of all state-funded primary schools in England and nearly 77% of all state-funded secondary schools. Academies matter to public health researchers because over half of all pupils in England are now taught in them. Across local authorities, the proportion of academy schools ranges from between 6 to 93%. While there is no requirement on maintained schools to convert to academies, the stated ambition of the UK government in 2016 was that all schools should benefit from the freedom and autonomy that academy status brings. There has been an emphasis on supporting schools towards voluntary conversion to academy status and building capacity in the system. Multi-academy trusts are emerging, and the status of single academy trusts, those with one school, is still unclear. We are also in a shifting health policy landscape with the introduction of statutory relationships and sex education and the Mental Health Green Paper and associated trailblazer sites set up around England with mental health practitioners embedded in schools and colleges. In this context then, the rationale for our study is that education and health are inextricably linked. Healthy children learn better, and children who achieve their educational potential live longer, healthier and happier lives. Schools are also a workplace for a varied group of staff, and the health of school staff is known to be related to the health of children. Therefore, for children, young people and the adults who work there, schools are an important setting for achieving health improvement. If we want to continue to have health promoting schools, as public health researchers and practitioners, we need to work effectively with Academy Trust to maximise health gain and ensure that in doing so we focus on ways which evidence suggests are the least likely to increase health inequalities. Multi-academy trusts in particular can include large numbers of staff and students. If there is the potential to work with them, we might have considerable impact on health and well-being. Our study had the following aims. Firstly, to understand how we could best work with school academy chains to assist them in assessing the health and well-being needs of their students and staff, and also in implementing and evaluating the impact of evidence-based interventions. We also wanted to know how we could undertake new research in academy schools to improve the health of their students and staff. This was a qualitative study involving in-depth interviews with leaders of single academy trusts, multi-academy trusts, free schools, faith schools, federations, and also with non-school stakeholders who wanted to engage with schools around health promotion. Fieldwork was undertaken in 2018, and the data collected analysed using a framework approach. 30 respondents completed an in-depth interview with the lead researcher. 24 of these were from Academy trusts and one was the lead of a small federation. The academies within the trusts included a varying range of schools, including primary, secondary, faith, free and special schools. 3 education sector participants were leaders of faith schools and 1 led a free school. Other MATs in the sample were also responsible for some free and faith schools. The sample includes chief executive officers, head teachers and those to whom leadership for well-being of students and staff had been delegated. In addition, we also interviewed 5 non-education sector staff. These were individuals whose job role included working with schools on health improvement and education, including 2 staff from local authority public health teams and 3 from third sector health organisations. Full details of our methodology are included in papers that we'll signpost you to at the end of this webinar. So these are the findings that I'm going to take you through today. How Academy trusts in England perceive their role in health promotion amongst students, how decisions around health promotion are made in Academy trusts, the factors that inhibit and encourage health promotion in Academy trusts and schools, and how public health academics and practitioners might best engage with Academy schools to facilitate health promotion activity and research. It's hugely summarised into a half-hour presentation, but will hopefully give you the key messages that emerged from our work. Let's start with the attitudes held by Academy Trust leaders to health promotion in schools. All Academy Trust respondents acknowledged there was a link between student health and educational attainment, but they varied in their view of the role of academies in promoting health amongst students. Responses clustered into 4 categories. Starting at the bottom of the slide, a small number of respondents felt that academies had no responsibility for health promotion amongst students. A second category of response emerged where respondents held a very functional view of health as a key driver of student attendance, and also that academies should promote good attendance as a means of raising educational outcomes for students. All respondents who held views in these first 2 response categories were executive members of the Trust, for example the Chief Executive or other executive post. A third, more populated response category was a perception of health promotion as essential to remove the barriers to learning faced by many students. Respondents in this category, who were a mix of staff at the Trust executive level as well as school-based staff, tended to focus on poor mental health as a key challenge facing many of their students. Their view was that academies needed to support students with these challenges as a priority if they expected students to engage in learning. The final response category was a perception of student health as important in its own right as opposed to simply a determinant of attainment, and that academies had a duty to ensure students had the knowledge, skills and opportunity to lead healthy lives. Respondents with this view were again drawn from all levels of the trust hierarchy. Of course, in reality, this is a sliding scale, and people moved up and down it even during the course of our conversation, often depending on which aspect of health and well-being we were talking about. The aspect of health that school respondents were most concerned about was student mental health. This is far and away the key concern, and respondents were aware that young people were facing threats to their emotional well-being that were nothing to do with their educational environment, but also that the school environment could make that worse or bring its own pressures. Respondents felt that schools had a role in helping students cope with pressures both inside and outside school. Other issues that frequently emerged as concerns of school respondents about their students were nutrition and obesity, physical activity or lack of, sleep deprivation and risk behaviours. So, as researchers seeking to work with Academy trusts around health promotion, an obvious question was at what level should we focus? Where in the trust are decisions about health promotion taken? In our sample, we found a range of models existed in multi-academy trusts. There were those that had a MAT-wide strategic approach with allocated funding for health promotion, those multi-academy trusts that had an implicit implied approach, and those that did not attempt to coordinate health promotion amongst the academies in their trust. And in single academy trusts and academies within multi-academy trusts, there were those who had a strategic approach with funding and those with no strategy at all. This figure shows how academy schools varied in their approach to health promotion, depending on whether they were part of a multi-academy trust or a single academy trust. If we start with maths, there were some in our sample which had developed a strategic approach that was being implemented in all academies within the trust, with funding allocated from both a central MAT budget and also an expectation that some resource from individual school budgets would also be used. A key commonality in this approach was a trust policy for student health developed at the executive level and then implemented by schools. In contrast, there were also MATs that did not attempt to formally coordinate health support for students across the trust, but chief executives or other members of the executive team would set the tone and direction. A number of respondents from trusts within this group stated that the approach to health promotion was implied or agreed, and academy leaders would be expected to implement strategies that complied with the central view, but no written strategy or central funding existed. However, in our sample, responses indicated that most multi-academy trust executive teams did not attempt to determine any strategic MAT-wide approach, explicit or implied. In the main, most academy schools retain autonomy over health promotion, regardless of MAT or SAT membership. Respondents from single academy trusts and from MAT academies where the trust executive did not attempt to coordinate or influence health promotion in member schools were clear that academy head teachers were responsible for how health promotion was prioritised or not, what strategy was implemented, and how much funding allocated. These two quotes from multi-academy trust leaders illustrate some of the reasons why MATs do not attempt to coordinate health promotion in their member schools. So the main message from our study is that decisions around health promotion are taken in schools, not trusts. Most academy school respondents in our study suggested that schools remained largely autonomous around health promotion, regardless of their status as a member of a single academy trust or part of a multi-academy trust. Most often, these decisions are led by the head or the deputy head of the school. A trust-wide strategic approach or ethos is rare. And this finding was supported by those respondents from outside the education sector that we spoke to. This quote from a local authority public health officer shows the importance of the relationship with individual academies rather than any central MAT leadership or executive. So let's move on to look at what supports or prevents health promotion in academy schools. Starting with the factors that prevent health promotion in schools, it probably won't surprise you that financial pressures emerged as one of the most important. Several respondents told us that this was the worst financial situation that they could recall. And in those circumstances, they were unwilling to invest in health promotion activity, but also because this was an area they felt less confident in knowing what was worth investing in. The second most important factor preventing health promotion activity was schools' focus on attainment and attainment measures. These were seen as the core business of a school, and schools would need to be in the right place with regards to attainments and performance measures before they felt able to attend to health promotion. Many schools said that they were struggling to achieve an appropriate balance between raising attainment and promoting well-being. And this quote from a chief executive of a multi-academy trust illustrates how trusts struggle to get the balance right between health promotion and attainment. And it's not just academy trusts that have this problem. This quote from a local authority public health officer shows how even maintained schools are pressured to raise attainment first before they can concentrate on health promotion activity. Another factor that emerged that may be preventing health promotion activity in academies is accountability or lack of. There was little sense in the respondents in our sample that health promotion was recognised or valued by Ofsted, although this may change with the new inspection framework and the introduction of statutory RSE. Many sources in our study also talked about just not knowing what to do, what the evidence was for health promotion, what would work, what the links were between health and attainment. Most people were simply Googling for research, so there's obviously still a lot of work for us to do as health researchers to make our studies more accessible and practicable for schools. Moving on to what encourages health promotion activity in academy schools, there were some respondents who told us they felt they had no choice. They talked at length about the challenging circumstances, for example, local demographics, poverty and austerity. Some were regularly signposting students and parents to food banks or running food banks themselves, and the mental health impact of this on their students, plus the prevalence of drug, alcohol abuse, crime and domestic violence in their communities were having on their students meant they had no choice but to address all of this or try to before they could function as a school. Unsurprisingly, health promotion activity also requires leadership, having someone in the school who sets clear priorities and strategies with an allocated funding stream. It's important that there is someone like a chief executive or a head teacher that gets it. And by gets it, we mean someone who recognises the link between health and attainment, in particular the links between mental health and emotional well-being and educational outcomes. Finally, the schools in our sample were more likely to be using research and implementing evidence-led health promotion interventions if they were supported by external partners with health promotion expertise. For example, we had a single academy trust using the ACEs scale on transition to secondary school to identify pupils at risk, and they were introduced to this by the local authority Healthy Schools team. We had a MAT working as part of a CAMS-led pilot linking schools and mental health services. This was CAMS-led. We had another single academy trust taking part in a Head Start pilot aimed at support within school, home, the community and online, taking a preventative and early intervention approach to equip young people to cope better with difficult circumstances. And they were doing so because it had national support and evaluation behind it. Finally, we asked the respondents in our sample about how we could encourage them to engage with academia and public health practitioners. Our first question was, if we as public health researchers want to engage with academy schools and multi-academy trusts, who is it that we should approach? What's the route in? Unfortunately, there were as many answers to this question as there were trusts in our sample. There's huge variation in trusts, therefore huge variation in how best to engage with them. In our sample, there were conflicting responses on whether or not we should approach multi-academy trust central teams or individual schools, and within those schools whether head teachers were best placed to approach or whether we should approach someone else in the school team with responsibility for health promotion. People were also conflicted on whether or not larger or smaller multi-academy trusts would be more open to an approach from health academics. Overall, though, most people said that multi-academy trust leadership teams would not be interested, rather we should contact individual schools, and within those schools head teachers were best placed to take the lead on health. And other health practitioners in our sample seeking to work with Academy Trusts reported similar findings. It's very hard to work with a whole trust. Instead, you have to go school to school. We asked our Academy School respondents what would encourage them to engage with us as academics. They wanted early engagement on our research plans, including on identifying knowledge gaps, agreeing research aims, and also jointly creating a methodology that would work and was practicable in their schools. They wanted a longer lead time for research that would fit with their planning cycles, allowing them time to engage their staff, students and parents, and they wanted flexibility and the avoidance of overly prescriptive timetables and research procedures. They wanted limited impact on curriculum time, saying that schools were approaching the point where every lesson counts, particularly in secondary schools, and they also wanted limited impact on the workload of their staff. For some, but not all respondents in our sample, for them to engage with research, there would need to be a clear link with attainment and some evidence that attainment outcomes would be measured as well as health outcomes. So, in conclusion, over half of all school students in England attend an academy, and around 1/3 of state-funded schools are academies, so academy schools' approach to health promotion matters. There's huge variation across academy trusts in their approach to health promotion amongst students, and most multi-academy trusts do not have a trust-wide health policy, and there will be variation within trusts as schools retain autonomy over health-related decisions. For the respondents in our sample, student mental health is a priority, and they perceive little or no external pressure to prioritise health promoting activities, for example from Ofsted or the Department for Education, although this may change. But in the current absence of national policy and guidance around health promotion in schools, health has variable status in academies in England, and in most cases decisions around health are made within schools and not trusts. The key barriers to health promoting activity are financial ones, as well as a focus on attainment. Strong leadership, recognition of the link between health and attainment, and of the key health challenges facing students encourage health promoting activity in academy schools. Academy trusts also want evidence of effectiveness, and this includes on health and educational outcomes, so we need to be better at communicating the links between health and education outcomes. In our study, where academies had the opportunity to work in partnership to deliver health initiatives, they often did so. This strongly suggests they would welcome more support from public health partners. If you would like more information about this study, including on methodology and more detail on the findings, this open access article was published in BMC Public Health this year. We've also produced a shorter two-sided policy Bristol paper, which is available at the link at the bottom of the slide or by contacting us and we will send you paper copies. Our contact details and that of the School for Public Health Research are on the slide.